Thank you. Thank you for the opportunity to talk about this topic. So, yeah, nothing to disclose. I'll have to wait these 9 seconds. Yeah. So, traditional anti-reflux methods, fundoplication, is effective and safe, but carries the burden of possible short and long-term adverse effects, dysphagia, regurgitation, gas bloating, diarrhea, etc. Now, Refluxstop, and I'll go into this a little bit more in the next slides, is a new implantable device that avoids compromising the food passageway based on restoring and reinforcing the angle of His. It's kind of an angle of His on steroids. We have data from Europe. FDA clearance is underway and should be coming this year. We have like 1 or 2 year, or 2 year data, and I'm presenting you now our 3 years data. So what is Refluxstop? I'll keep this brief as we have talked about this in the last session. So CE certificate in 2018. It's an implantable non-active device. With the goal to have a bulk under the diaphragm that keeps the esophageal length in the abdomen, so that the abdominal pressure really can exert its positive pressure on the LES. And again, it does not affect the food passageway. What consists the procedure of? So it's actually the same as a kind of the same as a fundoplication, high dissection, esophageal mobilization, hydroplasty as usual, but then it's a lateral restoration of the angle of His. That's one thing, over more than 4 centimeters, if ever possible. And then we invaginate the device, this Refluxstop device, which is a silicone ball, into the fundus as high up as possible, again, to create this bulk that really keeps the whole esophageal length in the abdomen. Now to this study. So we included all our patients with a follow-up more than 3 years. So we started in September 2018. We assessed the outcome subjectively with a GERD HRQL questionnaire at baseline 6 weeks and then every 6 months, but also an objective functional outcome parameters. So this is the standardized pre-op functional evaluation with 24-hour pH manometry, a swallow, and an endoscopy that we did also at 1 and at 3 years follow-up. Mean follow-up again, 3.5 years. Starting with 3 years, we have 22 patients that we followed up. Mean age 51 years, almost half female, BMI 27. And you can see the pre-op characteristics yourself. So almost a quarter had Barrett's esophagus, and almost half had ineffective esophageal motility. How did GERD HRQL score evolve? So a persistent improvement of these scores, starting with 24, but then they stayed down at 4 and 2.8 over more than 3 years. Use of PPIs, baseline, everybody needed PPIs. After 3 years, we had 2 patients taking PPIs for reasons not other than actually reflux. And in endoscopy, we didn't see any progression of Barrett's. We had 1 patient with mild LA grade A esophagitis after 3 years. How did primary presenting symptoms evolve? So you see on the left side, obviously mostly typical symptoms, but also dysphagia and respiratory symptoms that we use this. And on the right side, mostly gone or improved, and we have 2 patients where these primary presenting symptoms stayed the same, but no worsening of symptoms. What about the whole bunch of symptoms? So the typical GERD symptoms resolved in more than 90%. Dysphagia and pain in over 90%, respiratory symptoms in all of the patients. We didn't observe any de novo bloating. In 1 patient, but and this is also an indication for me for these kind of procedures. Pre-op bloating resolved in 83%, and we didn't see any post-op diarrhea. So to conclude, it is a safe procedure. It resulted in significant improvement in GERD in subjective and also objective, even though we didn't measure acid in all patients over 3 years. We didn't see any de novo dysphagia, no diarrhea, and I think, or actually preoperative bloating was normalized in majority of patients, and I think this is a good indication for these kind of more difficult patients where we fail, or actually in the traditional anti-reflux procedures it's not that easy to treat those patients. Thank you very much.